Well, there are, as we know, a multitude of guidelines that are trying to define best practice, which should be better defining that patient journey. But I guess there's a high degree of variability across those and a high degree of adherence by clinicians to those guidelines.
Well, first of all, I don't think that there is that big variety in the guidelines. They're fairly similar. There are twists and tweaks in them. But if you look, most countries worldwide look at the European or the American guidelines. And they're fairly similar, although the Americans are much more complex to digest. And the European are much clearer. And they're fairly straightforward. But are they followed? No. In some instances, yes, but again, you have institutions that do not have protocols, or they have protocols, but doctors are free not to follow them. And you got in counties or states, within countries where you have a budget restriction, and you got formularies that say that you can use those drugs, or you cannot use those drugs, or you cannot use these drugs, and so forth. So again, yes, I think that the guidelines are fairly straightforward, but they are not followed to the extent that would definitely help patients not to get a second event.
Yeah. And the reasons why they are not followed is a very big discussion.
Well, let's explore some of those reasons. Let's at least scratch the surface of that
It always
discussion.
amazes me that that these guidelines are produced and we know what works, but we just don't do it. And there's no rules.
You think that you know things, but it's so much easier to look at an algorithm or follow that standard procedure, and then you have to understand, well, I can deviate from that, but I have to have a very good reason, because most of the times the algorithm is better than the doctor.
We know there's this gap fairly consistently in what guidelines recommend and what happens in practice. Unfortunately, for many of the recommendations, at only about half the time are the recommendations actually effectively implemented. And the reasons for that are complex. Part of the reason is that healthcare providers don't understand the guidelines and aren't familiar enough with what the recommendations are. I think the bigger problem in managing acute coronary syndromes and post-acute coronary syndromes is not the knowledge of what should be done, but it's having effective mechanisms in place to assure that that's accomplished. Have care pathways, communication lines, standard approaches and tools that can help achieve adherence to the guidelines in place.
So if we know there are challenges with adhering to the guidelines, the clinical guidelines at the moment, what are the ways we could approach tackling that problem? How can we improve adherence to the guidelines?
I think first we have to increase awareness of the guidelines and the guideline changes. And even if some of us think that guidelines are lagging behind the, let's say, the development of new drugs or new evidence, the life cycle of a guideline is quite short, about, let's say, average of 5 years. And many physicians, they, of course, they try to have a continuous medical education. They are not able to follow all updates of the guidelines. And even they are not able to follow all new developments of drugs or recommendations at all, but the guidelines are particularly difficult. So the initiative of the ESC, for example, to provide the small condensed booklets, putting all guidelines in a small booklet of 30 pages, for example, is a very good idea. Some ideas that Gunnar touched on, for example, to have an app where you have a patient flow that is also linked to guideline, and where you can check where if the next step you are doing with the patient is guideline compatible or not.
And you touched on there the aspect of technology and apps and how this can help integrate the guidelines more into practice.
Yes.
There's a broader discussion there. So are there opportunities within broader management of secondary prevention for new tools or diagnostics? Is there a need for greater digital investment across the spectrum in this area?
Yeah, I think that there's a great opportunity, and we now have the technology to do that. 5 years ago, I would say we did not have the tools, we didn't have the smartphones or the pads, we didn't have the app technology, and now it's quite not easy, but it's easier to implement.
If we look just a few years forward, it's enough to go and look at the lunchroom here. People are not talking to each other any longer. We're sitting like this, right? And I can imagine if we're looking at Generation Now or Generation X, when they go up and get heart failure or myocardial infarction, we're probably, I don't think we even can imagine where we will be.
Technology is not all about apps. And I keep coming back to the point that we need to do what we know works. And that's a really good place to start. And I know there's a lot of people that are, have innovation titles and digital titles, but it's not all about that. But it is a disrupting technology. It can leapfrog gaps in systems so that you don't have to do what the Western countries do. You can go straight to a technology solution rather than trying to do something that maybe a Western European country has done very well. Put it potentially into a developing country, but actually you use an app and technology to do that. Yes, technology is an absolute disruptor. It can leapfrog, can go over potential issues with the existing infrastructure, which we work to, and it can take it to that digital level where people...
But to that point, I mean, we're with apps today.
Yeah.
But technology in general, what's happened in the last 20 years, and I said we're looking a few years forward, but if we look further, I mean, what will happen? Will we need doctors? Will we need anything? I mean, what can we do from a treatment perspective? What can we do from things like that? So I'm just imagine the future, and I'm so sure.
And that's where healthcare systems lag, are behind the cutting edge technologies.
Oh, we are conservative.
Because yeah, absolutely, and we need to be conservative for safety, but. If you look at Google, or Google, like prime example, it has to innovate every second. It has to, and maybe not use the word innovate. It has to invent or acquire, or has to be visionary in what it does every second of the day. If it doesn't, it becomes obsolete.
Right. But yes, we're lagging. We're conservative, but not that. I mean, look at what's happening in cardiology, and the stent started. And now you do smaller interventions with a lot of things that cardiac surgeons only did earlier. So I mean, come on, the development in and how pacemakers work today, and things like that. I mean, technology is coming, and yes, we're lagging compared to Google, but I think the improvement in healthcare has come very, very far.
The guidelines, as we touched on before, are based upon population data, whereas a physician has a patient in front of them that has their own individual circumstances. Is that one of the challenges we're now facing?
So back to the change that you're talking about, the patient influence, and I think that has changed quite a lot. If you go back and you look at different generations, the doctor said something and you did what the doctor said, at least initially. Then when the symptoms disappear and you stop taking your medication. But today, I think that doctors are challenged in a much more wider perspective with the internet, and patients come and have ideas about things. So I think that could probably disrupt the guidelines and say that, yeah, you say that I should take this lifelong, but do I need to? I saw an article yesterday, I Googled blah, blah, or I found that. And so I've had many colleagues that are challenged in their decision making. And when you go to a GP today, there was an article in the Swedish newspaper recently that with the use of antibiotics, for instance, that the patients come, I want antibiotics. Mm-hmm. They don't come for the advice of the doctor. They come for a service from the doctor, so to say. So I think that could be a problem.
Well, I think here we have to be very very cautious, because if you, as a patient who is not a professional, goes to the internet and collects information, on the topic the patient is interested in. He will find the huge variety of everything. He will maybe find information where he will be trapped. He comes with this information to his physician and say, I heard something about issues with statin therapy and I stopped my statin, for example. I'm now taking vitamins and so forth. So I think informational material is necessary, is mandatory for the patient, for his information, but that must come from a reliable source, must be very neutral, product independent, probably independent from industry, and having a brand mark from let's say governmental or a more neutral authority, maybe not the insurance company, because we do not know if they are neutral, but information material is paramount in this setting.
This is a huge conversation. So, in terms of so let me take it in two parts. Okay, so in terms of influencing the guidelines, I know patients who take NICE or ESC or guidelines to their physician and say, hey, this is what they say. And some of those doctors say, well, I wrote that. So that's good you've taught it. But absolutely to disrupt and for a positive outcome, guidelines and ways things are done.
So I think this underpins one of the challenges as I see it, and I'd like to spend a bit of time just building on this. You know, we were talking about guidelines, and we've had some really good examples here. So you mentioned a patient going to an individual website. You know, sample of one may or may not be reliable. We have, you know, counselling opinion from a forum, a number of views, but not necessarily peer-reviewed, and we have guidelines, which are kind of at another extreme. A great number of scientific organisations or medical associations put their input into them. They're peer-reviewed. There's a wealth of data, but obviously that makes them quite slow to produce and slow to change. So how do we find a balance amongst all of this? How do we become more nimble, but still, and we have to, maintain the level of scientific rigour behind the evidence that underpins them?
Yeah, I want to come here back because I think that is a key variable to improve quality of healthcare delivery. I think that there must be liability to recommendations. Let's say there are some countries where if you do something wrong on the patient, you violate the guidelines roughly, you can go to a lawsuit. In the US, this is of course the country where it's best known. Everybody asks after his heart attack a lawyer to make some money from some malpractice. That is not so common in most European countries, and in some countries it's not existing. So there is no control on the quality of care delivered by healthcare professionals. For that, so they don't need to follow guidelines because they are not punished by not using guidelines or by doing malpractice. This is the other side of the coin. And if I have a social network with a lot of patients who get involved into a question of a patient, who takes liability if this information is wrong?
You can't stop what's changing. It's a movement. It's not. It's a social change. It's not. And what we should be doing is we should be embracing that opportunity and saying, how do we actually drive that in a safe environment? And it's not about, you know, healthcare professionals need to be good healthcare professionals or good professors of whatever, but there is a new emerging market of, you know, patient advocacy has grown significantly and has significant influence, you know, since I've been doing it, and over the last 3 or 4 years, that's just accelerated. And now the payers and the governments and the agencies involved in healthcare provisioning and system provisioning across the globe are all looking to the patient for insights. So we should be working with these community groups.
We have an increasing focus now on patient engagement, and I think this is critically important, especially for something like transitions of care and secondary prevention. That that our traditional model of having a healthcare provider provide instructions to a patient as they leave the hospital and expect that that's going to be effective has been naive. And so I think having patient engagement, including patient representatives on guideline committees, on government committees to decide how to couple reimbursement with performance, is something that's critically important. The American Heart Association has done a very good job with this. We have this patient-centered outcome research institute, the PCORI Institute in the United States, that's highly focused on this. And I think it's already been very fruitful. Engaging the patient more completely is something we've got to be more effective at doing to be more successful with secondary prevention.
As I see it, there's fundamentally three areas of focus here when it comes to guidelines, and I think you touched on some of the issues of whether people then implement the guidelines. I mean, essentially you've got, are the guidelines reflective of the best evidence from all perspectives, patient, clinician, and if you believe that's okay, then okay, can we adapt and update them rapidly in the face of novel interventions coming through? And if you've done all of that, are they being followed? Are they being adhered to within specific markets? And if we've ticked all of those boxes, then we should be shifting the needle when it comes to good patient outcomes. So is our real challenge more around following the guidelines? Is it around the rapid onward development of guidelines? Is it about the front end of having the right evidence and the right input? Where do we think the challenges lie there?
Well, I definitely think that from a scientific perspective, they are very, very, very condensed, up-to-date, well thought through.
Yep.
Top intelligent clinicians, scientists, epidemiologists that scrutinize the data and make an evaluation that I think is extremely valid.
Yeah.
Yes, I fully agree, Gunnar, fully agree. And for me, I would say the guidelines is the piece of information I always read before I start a new prescription or a new strategy, because you are right, you have the condensed, novel, updated information on, I would say, across cardiovascular disease, there are good guidelines. However, I would say 2/3 or 60% of guideline recommendations are still in a level of expert opinion. It's a C recommendation. It's not a 1 or level 2A or B recommendation based on multiple trials, well-performed trials, but it's expert opinion. And here we have the freedom to decide here and there. Second limitation is that the studies that are the basis for the guidelines have excluded some patients systematically, like the elderly, women, patients with severe kidney failure or end-stage renal dysfunction. So the high-risk groups we talked before, they were excluded from the studies that were used to derive the guidelines.
Yeah, but there's a change coming, and I mean registries probably will play a much bigger role in the future, and hopefully, and the FDA is just having a seminar on that. How can constructed registries or actually registry conducted trials, randomized trials, be something in the future? Because there's been so strict about how you conduct a trial to make sure that the quality of the data is so good that they can be in the guidelines. But it's very expensive to do trials in that fashion in the future. And I think that registry will cover more all comers. I mean, from a randomized controlled trial, if I have 100 patients coming in, how many of them will I introduce in a study? Maybe 2 or 3 of the patients, which means a very selective patient population. But registries can cover all the patients, and therefore you get a much better picture of how it really looks.
In the real-world evidence area, I think the most important thing in these registries that we all are participating in, I think the most important thing is that we use these to measure how are we performing in applying evidence. And they're critical for that. We have to be measuring how are we doing in assuring that patients are on the simple, proven, effective treatments to reduce cardiovascular events and improve survival after acute coronary syndrome. And so I think we all have an obligation to be participating in registries to measure and feed that information back and to understand how are we doing compared to our peers. The motivation of competition is a very effective one, and if I see that the hospital across town is doing better than I am in the proportion of patients that are actually on a P2Y12 antagonist 30 days after their acute coronary syndrome, then I'm going to want to do better.
But we still need to get novel interventions into the system in order to generate that real-world evidence. And I think you touched on it takes time for this data to come through. There are data gaps. I mean, are there ways that we can accelerate that process? Or is that the really tricky question that we don't have an answer for at the moment?
Yeah.
Well, I think the way to accelerate the process of innovation is to run in parallel with registries and work that randomised controlled trial or whatever trial you run and push it in a direction. But creating a need is everything, and that's where patients come into their own, really, because why are we all doing what we do?
So if we look at secondary prevention, which is obviously is the key topic here, where are the gaps at the moment? Where's the unmet need that even if we're following the guidelines to the letter, there are still challenges, there are still problems, there are still patients experiencing recurrent atherothrombotic events?
The guidelines, of course, are evolving, and there are major continued gaps in knowledge and controversies, including in the post-acute coronary syndrome setting. But I think the two areas that are the most important for research are how do we improve the transition of care? How do we make sure that in this time of vulnerability for patients no longer being adherent to those treatments which are already proven to substantially reduce the risk of recurrent events, how do we make sure that the simple things are more universally applied over time, especially over that year after acute coronary syndromes? And secondly, what are the exact elements of an intervention program that are effective? Because there's so many there's so many tools that are available.
I do think the guideline, the people who run the guidelines are very much more open to the influence of good quality of life data versus the hard endpoint stuff of mortality or hospital readmissions. And I think the patient groups and the patients just need to get really, really good at encapsulating the community's information or the community's feelings and needs and actually delivering that in a package that works and influences those changes. So I do think that is coming.
So is that one of the key unmet needs here? I think this is a really important point. I'm glad you brought it up because the clinical aspects of guidelines and treatment clearly are important. We want to stop people dying and some of those really hard endpoints. But the quality of life input, while people are living with a condition and trying to live their lives without the burden of it, is that something that we think increasingly will be part of the guidelines moving forward? And what does that process look like to make it part of the guidelines?
Yes, definitely. It will be much more important in the future. But still, I mean, saving lives, mortality benefit would to me is the prime. It has to be. I mean, that's why I became a doctor.
Yeah. And with the current guidelines, I just want to explore a little bit around, because obviously the guidelines cover a number of different aspects. What is the balance between pharmacological intervention for secondary prevention versus other factors at the moment? And is that balance in the right place potentially?
I mean, it's crystal clear. Number one is continuation of dual antiplatelet therapy. We know that continuous risk that is very high in the beginning and continues if you take your antiplatelet post NMI to protect you from a secondary entrant. Mm-hmm. And here we got class 1A. It's no doubt about that. Then there is some deviating discussions, which means that you get a little bit of lower evidence from the guidelines about how long you should do it. And there are some discussions here.
Which I guess brings us back to the issues around, concordance, compliance, all these wonderful terms of, whether that's working for patients at the moment.
Yeah, I'd say that this is quite a big statement. I'm going to get some kickback off this, but The domain of treating patients is not uniquely the doctor's responsibility. So absolutely, the guidelines should guide the clinical aspect of treating, of helping to treat patients and get them to have the best quality of life. And also, I agree with the endpoint, hard endpoint mortality is everything. But if you come to heart failure, it's hardly shifted. Okay. So quality of life, actually, from my point of view, from my patient community, is more important in some respects than the mortality aspect. But yes, absolutely, the treatments are paramount. But I keep going on about we need to look outside the domain of just the clinical stuff, and it's how we do that. So I don't disagree with anything that's been said. It's just and sometimes I wish that doctors would stop trying to own everything and work with other partners sometimes.